So we're at our last presentation for the day. And last but certainly not least, we want to welcome Dr. Raquel Reinbolt to discuss the latest in prevention, diagnosis, and treatment. I'm going to give some bio and background on you, if that's okay. So Dr. Reinbolt is an internist and medical oncologist with clinical and research expertise in breast cancer, therapy-related, and supportive care. She specializes in the diagnosis and delivery of clinical medical oncology care to patients in all stages of their disease, given her passion for enhancing care delivery and clinical operations across the cancer spectrum. Dr. Reinbolt now serves as the physician lead for the James Hospitalist Cancer Service and medical director for both the James Immediate Care Center and the James Cancer Diagnostic Center. More recently, she was named the medical director of the James Cancer Care Continuum, which allows her to draw on her unique experience across the ambulatory, transitional, and inpatient spaces. So incredibly honored and happy to have Dr. Reinbolt with us. Thank you.
Thank you. Thank you very much. Appreciate the chance to be here. Well, they said I'm the last speaker, so that's a lot of pressure. I'm between you and running out of here. So that's always like the worst spot to be in. No, that'll work just fine. Well, as I said, I'm thrilled to be with all of you. I am one of our associate chief medical officers here at the James, and have been very fortunate to kind of have my hands in a lot of different spaces over time. And so, this is a big topic to think about, screening, early detection, new treatment, et cetera. So we'll see what we can kind of hit along the way and share with you maybe some solutions that we've come up with the James to think about when patients do come up with some sign or symptom concerning for cancer, how we go about approaching that. But really, and I apologize if you've hit some of this data beforehand or you're familiar with it, I'm going to borrow a lot of this from the American Cancer Society. They have really a wonderful slide deck if you haven't seen it, and some fantastic stats that they keep updated very nicely. But it's important to understand kind of where we are to think about where we need to go in the future. And so, this is the estimated number of new cancer cases for 2023. And so when I'm thinking as an employer about my employees, cancer is everywhere. It does not discriminate. It doesn't care if you're a very nice person. In fact, I always feel like it always hits the really, really nice people. That's why I'm in this business. I'm kind of feisty person. And so that ticks me off. But it doesn't discriminate. It's everywhere. And you can see, particularly in Ohio, our numbers are relatively high. When we think about for male and female, what are the most frequently encountered new cancer cases for 2023? I don't think a lot of this is surprising data. Of course, prostate, lung, colon for males, and of course, breast, lung, and colon for females as well. But I thought this was actually pretty interesting. And so again, this is all from the American Cancer Society. But this is your probability of developing invasive cancer during these selected age intervals. And so when I'm thinking about this as my friends, my family, when I'm thinking about this as an employer, look at these different age groups. How many of your employees fit somewhere into this? Okay. And look at kind of your lifetime risk, here from birth to death of getting cancer. Breast 1 in 8 is kind of the number we often hear about. But you can see, our younger populations are affected. And certainly when we get into this age range of 50 to 59, 60 to 69, it starts becoming a lot more frequent. Something to be aware of. So how are we doing with the treatment of cancer? And so looking at our 5-year relative survival rates, and this is over time, I would hope we're seeing improvement, right? We have all these new exciting drugs we've been talking about, thinking about the cost associated with them, but it is making an impact. And you can see, especially in which disease states, we are starting to see some of that impact over time. But the reality is we still have a lot of people who die from this disease. And so when you look at our survival rates by stage, so the way I see, local, this is when cancer it's staying in its current organ system. It has not spread elsewhere. This is where we have the best opportunity for early detection. And you can see that the rates of survival are significantly higher here compared to when the disease has moved elsewhere into that metastatic or distant spread stage where we're not going to cure them. We're going to hopefully prolong life in a meaningful and way. But that's one reason why I would say screening, early detection is so critically important. That is our best window to do something about the disease. And then, unfortunately, as I said, there's a high toll with cancer. It is a very, very challenging disease state. We are fortunate it's much more of a chronic disease when we do catch it in the later stage for many of our cancers, because we are coming up with new therapies and ways to support our patients. But we still have a lot of work to do. And that's one reason, at the James, we're so proud of our work in clinical trials and trying to come up with what are those new therapies and ways to help patients, whether it's at the kind of end stage where we're trying just to support them, but ultimately working toward cure. And so I no one wants to talk about COVID anymore. I think we're all over it, right? I am, my goodness. But the reality is this had a major, major impact, not only on healthcare, but certainly on cancer. There's an estimated 22 million cancer screening tests were delayed in that first year of COVID. That is significant. And we're going to be seeing more and more kind of data later on, kind of what are the kind of the waves of what happened because of that. We noticed at the James, no one wants to go to the hospital, right? We were all buckled down with our families in our homes. And so no one wanted to come to the hospital unless they absolutely had to. Those symptoms you might have been having, I'm just going to ignore it for right now. This test, I'm supposed that mammogram, I'll get it like in 6 months, maybe next year. Okay, that was a lot of the mentality. And so, for us at the James, when we thought about this problem, knowing the realities that early detection is important, not ignoring those signs or symptoms that might be concerning for cancer, all superimposed on the story of COVID, which basically, like I said, people were ignoring those signs and symptoms. They didn't want to come in. How could we reach out to those folks and still get them kind of that diagnostic testing they might need? Okay. So one of our solutions at the James was to open the James Cancer Diagnostic Center. And so we actually started planning this in the summer of 2019. And as COVID hit, though, and acknowledging that many of our patients were kind of staying home, or patients that were maybe not James patients yet, but had something worrisome were staying home, we decided to kind of accelerate the progress on this clinic. And so the goal was to be able to reach out to those, even in their home, using telemedicine. I will say maybe that was one silver lining of COVID that came about, is we're a little bit more familiar using that technology. But how do we say, we can at least have a conversation via telemedicine. We can hear what your signs and symptoms are concerning for, and then kind of go from there from a diagnostic standpoint. So the Diagnostic Center wasn't necessarily to catch people up on their screening. It's a clinic designed to say, you're having a physical symptom, you have a lab test, you have an imaging abnormality. That's not quite right. And how do we work through that? And so we accelerated opening this up, opened our doors in July of 2020. Did a lot of early work, though, to make sure that our specialists would be working in partnership with the Diagnostic Center. So they have helped build kind of a lot of the approaches or algorithms we have to various signs or symptoms that might come in our door. And similarly, from a diagnostic standpoint, we partnered a lot with our interventional radiologists, other radiologists, to make sure that we have that infrastructure and close connection to interpret some of these results. And I will tell you, I kind of get to hear all the really, really hard cases that come through, and they're very challenging stories sometimes. So there's not always a clear pathway of how to work someone up, but we're very, very lucky kind of from early on getting, all of our experts engaged in the clinic has been very successful. So the clinic, as I said, we really see anyone with a sign or symptom concerning for cancer. Plenty of patients who maybe go into an ER, have some abdominal pain, they get a CAT scan, and while their abdominal pain is something totally unrelated, now we see a spot on the liver and we're not sure what that is. Something as simple as that. We are open Monday through Friday, typical hours. And as I mentioned, that virtual visit, especially initially, was really important when you think about kind of the pandemic and people wanting to stay home and so forth. So we do accommodate that still have plenty of in-person visits, and we are also at Dublin too. The other piece of this that I would say was, driven in thinking about just access to care, some of the pandemic and so forth, was the ability to self-referral. I mean, as all of you know, some of our friends and families are well connected with healthcare, others are not. And so, we felt it was important for this clinic that you didn't have to have a referral from a physician necessarily to come here. So patients are able to pick up the phone and call themselves too. How does this work, and what has our approach been to date? So generally, we try to do our homework before anyone arrives. So if they had that scan done at a local ER, we're getting all that imaging in and kind of have a sense of what's going on before they even walk through the door, of course. And then it's more of a kind of comprehensive discussion of, what other signs or symptoms can we find here, walking through what to expect. This is a time of high anxiety. And I will say, as thinking about being an employer, this is a time when people are stressed out, trying to balance work, they're trying to balance family, and the what if. Do I have this diagnosis? And it's kind of hanging over their head. As much as I would like to tell you, I can get all of my diagnostics necessary, from labs, imaging, biopsy, all done in a day. We often are not that successful. I wish we could. It's something that's kind of our North Star we work toward. But that time to get a diagnosis and that worry, that does eat at people. And that's one reason why we try to spend a lot of time just educating folks who come through our door on what to expect and kind of what this diagnostic journey or process looks like. If a cancer is confirmed after we, do our appropriate imaging and labs and so forth, we do a handoff, of course, to the appropriate cancer specialist. But if it's not, we actually work hard to say, okay, where's next for you? Is that back to a primary care physician? Did we find something that was concerning from a pulmonary standpoint? And you should see one of our pulmonologists and so forth. So we try to at least kind of get folks pointed in the correct direction. As far as our team goes, so the clinic is staffed by 2 full-time advanced practice providers. They're outstanding and have a wealth of oncology experience between them. Actually, one who was more in kind of the solid tumor area, and one was more in the hematology area. I back them up, as I said, for the hard questions, although usually when they give me the hard ones, I go, oh my gosh, we're going to have to send some emails and get a powwow going here. So we have wonderful nurses who also have a wealth of oncology experience. And so, as I mentioned from the get-go, we work hand in hand with our hematologists, with our oncologists, with our surgical oncologists, et cetera. And they've been really a great part of this clinic. They invite us to their multidisciplinary tumor boards. We work in very close proximity to our interventional radiologists and so forth. And then, as I said, we try to get patients to the right place if it isn't cancer, which we hope it's not. One example of how this worked out, we had a patient who essentially went to go see family over the holidays, kind of got worked up, as I mentioned, kind of like that ER example, found a liver lesion, decided I'm going to come back home to get this done. Basically, within a 2-week span or so, we were able to get a PET scan, get a biopsy, get the results. And unfortunately, it showed a high-grade, poorly differentiated neuroendocrine cancer, which, if you're not familiar with it, is sometimes a nasty cancer. This is a cancer we sometimes admit patients to the hospital to get inpatient chemotherapy started. But we were actually, because of this, able to call the oncologist, give them a heads up this was coming, and she was actually able to start therapy outpatient the day they first met. Okay, so I consider that a win. Again, I'd love to take that 2 weeks and shrink that time scale even more. But that's certainly a challenge we continue to work toward. But making sure we have access for our patients, making sure we have all those kind of diagnostic facilities and opportunities is something we continue to look at. This is very busy, but it's just to say, what do we see in the clinic? What comes through our doors? What are some of the things that maybe aren't picked up on kind of standard screening tests like a mammogram or what have you? So plenty of liver lesions, bony lesions come through our doors, kind of lumps and bumps, if you will. So adenopathy, a wealth of different things. And we've been growing over time. So this is really from when doors opened, as I mentioned, to current state. Yellow is our new patients. Blue is established. And so we're a busy clinic and certainly growing. Always able to, partner with primary care. We have specialists who are sending things to us. Patients call themselves as well. So kind of a lot of variety of where patients start from to come through the clinic doors. So I mentioned, again, this, and it's obvious that this is a stressful time for our patients. But we really try to take a concierge-like approach when they come through those clinic doors, and really, again, spending a lot of time on that education piece and how do we work through and navigate that anxiety. Some of these folks may have gone to the ED with abdominal pain and had one of the care providers say, "Oh, we found a mass in your liver." No real explanation. Go home and follow up here. So we don't know kind of where that person's coming from, what they heard, and how when they walk through our door, kind of what state they're going to be in. So we try to do a lot of work around that piece. The other thing I think it's important, though, is getting the cancer diagnostic process going takes time, but it also takes people out of work. It's a lot of out-of-pocket costs. It's transportation. There's a lot of logistics associated with this. So we do believe that the Cancer Diagnostic Center has offered some solutions from that. So, for example, when patients are in our ED, oftentimes they're sent there with maybe from our primary care doc and says, "This is concerning for cancer. They need to go to the ER and get this worked up." The reality is many of our cancers, it is an ambulatory workup. And we actually prefer to do it in the outpatient setting. But again, that anxiety, that fear, that panic, we have to go get this done right now. So they go to the ER. So we have partnered with our ER to say, unless they have a reason that, acute reason that requires admission, maybe significant laboratory abnormalities, they're unstable for some reason, but if they don't have those, we'll see them tomorrow. And our clinic can kind of walk them through things. So keeping them out of the hospital, letting them be in their homes, letting them be with their family, letting them stay connected to work or whatever else. Similarly, if patients are in kind of one of our local or community hospitals, they might come in for a COPD exacerbation, and oh, by the way, if they found a lung mass, let's transfer them to the James. I would actually prefer, please treat your COPD exacerbation, discharge them once you fix that part of it, and then we'll take care of the lung mass and look at that as soon as they're discharged. So that's another opportunity, kind of, shortening hopefully that time that they're inpatient. No one wants to be in the hospital, at least not many patients I've encountered for the most part. It's much more comfortable at home. So let's get them home and then see them and get this going. We've also worked very closely with our primary care physicians. There is a lot involved in care coordination for that diagnostic process. It's a lot of emails going back. If it's unclear kind of what the story is, it's a lot of, hey, what do you think about this? What do you think about this? Kind of getting consensus opinion. And we try to do a lot of that work in the diagnostic center. We already have those kind of conversations and pathways laid out. And so for our primary care docs, not that they can't do the workup, it's just more, let us take this off your plate. And we'll keep you in the loop and kind of continue to work through things with your patients. And then similarly, kind of back to what I mentioned with the ED and referring hospital, we think about, what about the patients who are admitted? Sometimes we're waiting for a few days for a biopsy, okay? Especially in times, not just unique to Ohio State, but I think many healthcare institutions are struggling with staffing, with keeping kind of all the technology running on a usual cadence. They may not have technologists to do that, et cetera. So sometimes there are extra delays right now in care. And so how do we make sure that we're getting folks, through this testing as quickly as possible? I would argue, let's stabilize the patient, take care of the things that absolutely need to be done inpatient. And then again, we're partnering with our inpatient teams to say, the diagnostic center will kind of receive that patient once you've tuned them up and stabilized things, and then we can continue moving that diagnostic pathway forward. We were very lucky to receive a 2022 ACCC Innovator Award for this work. The other thing I think that is really cool for our patients that come through the diagnostic center is the ability to offer to link them with some of our research programs. So I think one of the most exciting areas of cancer therapies going forward, and just understanding cancer working toward a cure, is what's unique about your cancer as opposed to someone sitting next to you. And some of these research programs are looking just at that. And then can we take that unique finding and exploit it with a drug or other therapy that's targeted toward it? So what can we all do? Well, I'm going to borrow a little bit of what the conversation was started just a few minutes ago. But there are things we can do to try to prevent cancer, and spending more time on overall health, I think, is critically important. Okay. We have a problem with tobacco. We know this. And you can see that that's reflected in kind of the lung cancer deaths. So there's still plenty of room to go on improving this. Similarly with obesity, excess body weight increases the risk of at least 13 cancer types. How many of us sit at a desk all day? We don't really exercise much. We don't really make great dietary choices. And by the way, doctors are the worst. We're guilty of all these things too. I don't claim to be perfect here by any means, but we have a lot of work to do. We think about our younger workforce. I mean, there's plenty of data out there too on just, kind of our teenagers coming up, folks in their 20s, and how obesity is so heightened. So let's modify what we can modify. Let's try to do early detection when we can, and see, try to prevent what we can. We won't always be able to do that. We don't have the perfect tests that can find things, and sometimes we don't have the perfect drug even when we do find something. But we should take advantage of kind of the low-hanging fruit. I don't know that we do a great job of that. I'm not sure that we support one another to do a great job of that. So I thought this was kind of interesting data. So this was basically using Medicare claims data from 2000 to 2012, 2007 to 2013. And they were kind of used that to estimate costs based on cancer site, phases of care, and the stage of diagnosis. And so looks like it got cut off here a little bit, but what you can see is end-of-life care is a lot more expensive than kind of that initial diagnosis. And there's actually another, like I said, I think it's not fully showing, but the maintenance phase as well. Whether we're looking at the medical service costs, we're looking at their oral prescription drugs and so forth. Now, this data is a little bit antiquated, but it just kind of gives you a feel of, again, cancer costs are rising. It was said earlier, I'll say it again, but it's not about the money, okay? The burden on our friends, our family, on your employees is really significant. It's taking way, way too many lives. So early detection is value creation. Yes, sure, costs, that's great. But early detection is really important for these reasons too, okay? So again, wanted to leave plenty of time for discussion. This is a very, very broad topic. I wanted to share a little bit about one solution that James has come up with to get at some of those access concerns for when patients do have a concern for cancer. Talk a little bit about kind of, I think, some of that low-hanging fruit that we can all work toward, whether it's supporting our patients, our friends and families when they do get a diagnosis, or they're working through that process, or is it looking at those modifiable risk factors and trying to do a better job of kind of putting the carrot to work to improve those things. Thank you for your time. Appreciate it, and happy to take some questions.
Mic is available.
Hi, Dr. Reinbolt. Thank you for all the great information. My name is Corey Belkin with Genentech, and I was kind of curious. You mentioned in your case study, you talked a little bit of the value of like treating sooner rather than later. And I was just thinking as it relates to like with MS, I think the old adage is like time equals brain. So the sooner that you can start on like an MS therapy, usually the better outcomes with like a disease modifying agent. But I'm just kind of curious when you see patients that if they start on week 2 versus week 12, what does that really look like from an overall outcomes perspective? And earlier today, I think Robert kind of talked through some of the different patient journeys with maybe if they start with like a single gene therapy and then they go to a comprehensive genetic profile, and that all takes time and delays, access to treatment eventually. Is there any way that you can quantify that or give us a sense of what that looks like from an outcome standpoint?
Yeah, so that's a tough one. So it's cancer specific, I would say. There are some cancers that we need to do something. When we think about leukemias and things like that, these are very aggressive tumors, and we need to get going as soon as possible. There are other cancers that I'm not going to say they're well behaved, but maybe a little bit slower that we have a little bit more time to be thoughtful about things. When I did breast cancer work, it was kind of, can I wait till surgery this long? And trying to give estimates of what our comfort is. So I don't know that I can give you a kind of one size fits all for that, because it really is cancer specific. That being said, when I think about just in general, and maybe I'm doing a slight tangent here, so forgive me, but when I think about cancer therapies in general and the sequence by which we give certain cancer therapies, there is a rhyme and reason to that. I have a bag of weapons, I always tell my patients, and I'm thinking especially for more advanced or metastatic disease. And if I give this one before that one, then that might not allow me to give a different one down the road. Similarly with clinical trials, if I give someone this, then I might take them out of the running to be this trial is no longer an option. So being really thoughtful about the sequence of therapies, making sure we have some consensus about which therapies make sense when, I think is really important. So slight tangent there, but I'll just say, having delays to certain drugs, there's no doubt. Our patients want the medicines yesterday. I'm sitting next to them in the office and trying to explain why we're waiting for something. It's a tough conversation to have. It's reality.
Eric from Employers Health here. What type of cancers would you say are caught the latest? If you were to think of a few that could maybe things could be different if they're detected sooner.
Sure. Well, I think if we look kind of back at the initial, some of that American Cancer Society data, the things that we have screening tests for that we feel comfortable with, whether you're using the ACS guidelines or the USPSTF, if I'm getting that right, I always get the abbreviation wrong. Certainly those, I would say we have a higher likelihood of picking them up sooner. But some of our other cancers, unfortunately, and a good percentage of them, we're not going to see until, that you're having a symptom, you're coming into the ER for something, which is unfortunate. Pancreatic cancers, ovarian cancers, things like that, often kind of escape us until we're having a sign or a symptom. And some of that's because we don't have great screening tests to pick that up. I'm sure there's a lot of discussion now about kind of the liquid biopsy. I'm just gonna go there because I think a lot of people have questions about it. So I am not an expert in that, but I will say it is a fascinating area. It's very exciting. There's no doubt about that. The potential to try to, detect cancers early. Sure, that sounds wonderful. Getting folks to treatments earlier. A lot of good things can come from this. I think we just have to make sure that this is very much a pros cons still discussion. I think a lot of research still needs to be done to really understand kind of the generalizability of these tests in some ways. We have to understand how to navigate. What about if we have a false positive? You're told we picked up the signal and then we can't find it. Okay. That means that someone might be going through a lot of diagnostic testing that was unnecessary. That is a very stressful time. No one wants to be told we think you have something and then we can't find it. There's a lot of uncertainty that you have to cope with. Being mindful of how often are we still missing something. If we think about this in general for screening tests, if we pick this cancer up really, really early, and I'm, screening millions of people, is how often would it actually have a meaningful impact on their life? Is it kind of a well-behaved, slow-growing cancer that wouldn't have ever caused a problem? I don't know. So, there's a lot in my mind with those tests. I think it's incredibly exciting. I'm going to be following the literature on it certainly, but it still remains very much, I think, a individual discussion and understanding the pros and cons that come with it.
I have a question here, Jason, from Cancer Bridge in the James. And so Dr. Reinbolt and I work very closely together in many capacities. And I'm going to ask a question I'm targeting a little bit. So in Cancer Bridge, one of our clients was interested in GRAIL. I think ACS is positioned, many others, even FDA. I think those tests at home are still, again, under I think, review. But we had a client who was very interested in it. they want to pay out of pocket. They're proceeding with the testing. We then have the opportunity of the diagnostic center that she runs to then navigate them through on differentiated implications, or what additional screening can we do for the false positives or rule out the positives, right? So anything you can answer to that would be great, but I just bring that up as an opportunity to highlight how we work together.
Sure. No, thank you for that, Jason. Yeah, I mean, let's face it, the test is out, so people are going to be using it. And so I think it's really important, again, that we're kind of going back to the literature, hopefully that we see kind of larger and longer term studies to understand kind of the significance, to understand how many tests did people get put through that maybe weren't helpful. So we really understand those pros and cons. But at current state, if folks are getting that result, we do want to be able to help interpret it and help kind of walk through, well, based on this, okay, this is concerning for colorectal. Have you had a colonoscopy? Oh, no, I'm not up to date on my screening. And nudging people kind of to go through the correct pathways for it. So I think keep your eyes on it. It's interesting. We'll see where things pan out. And again, it's all about, trying to understand what is that unique signature of your specific cancer. Whether we're trying to exploit that from a diagnostic standpoint, whether trying to exploit that from a therapeutic standpoint.
Another question, Dr. Reinbolt, Eric with Employers Health. So many purchasers, employers and health plans, right, are promoting second opinions. So as an oncologist, what's your opinion on those?
On a second opinion?
Yes.
Okay.
What is your initial opinion on a second opinion? Yes.
Okay. Very biased answer. I think more minds looking at something is generally a good thing. I think we all have different practice styles. We've been trained different ways. I will tell you, even just personally speaking, when I have had challenging cases, I speak to my colleagues who are experts in that area to get their input. And I can't tell you that I've ever had a conversation that wasn't helpful. It always is. It's a combination of reviewing what are the guidelines out there. It's understanding what is new and upcoming, and trying to tailor that and personalize it to the patient. So, I'm an advocate for that. Certainly, I think getting our ducks in a row, dotting our I's and crossing our T's before we're jumping into a particular treatment makes a lot of sense. Some of what I was speaking to before, I don't want to use something unless I'm confident this is the time to use it, because if I use it, I might not be able to use X, Y, or Z later. And that's important. That's time. That's life. So that is important. I will also say, just from a collaboration standpoint, I also assist with our James Cancer Network, for example, and we've had some wonderful collaborations with, folks who want to stay home in their community. They have great physicians, but we're able to connect with their physicians, with that patient, and work together as a team to kind of put our minds together and say, yes, I think this is the next best step for them. So I think that's also a kind of an opportunity for really, great collaborations, great discussions, and helping the patient kind of, have a confidence that multiple eyes are looking on this and looking out for their best interests. Thank you.
Thank you.
Sure.
Hi, Cody from Genentech. And I'm curious, what barriers do you see patients come to you with and share that us as employers should be thinking about? How do we remove these barriers for them? And just curious the patient perspective from the provider view.
Sure. No, I appreciate that. So many. I think there's a lot of layers to this. So depending where they are in their cancer journey, if we're in the diagnostic process, it's the unknown, it's the anxiety. It's also the flexibility, whether their responsibilities at home, their responsibilities at work with their employers. I'm sorry, you have to get this test tomorrow. Oh, we're going to have to move it to this time. There's healthcare is, it's organized chaos sometimes, right? And so I think that's just one level of stress. It's even just the logistics and having the flexibility with work and so forth to kind of get done what needs to be done. That's just even in the diagnostic setting. Now let's do it. We've diagnosed you, we're treating you. there's a lot of appointments. I think, as providers, we're trying to be strategic about how do we leverage telemedicine? How do we try to combine appointments so folks aren't running back and forth all over? But having that flexibility is really critical for our patients. I had a personal example recently of someone who was going through kind of the process, and I think they reported that they got maybe 30 to 50 phone calls in like a half day, and they were trying to do their job. And it was just, it was just, that's an extreme, example, but patients are going to be contacted and ask questions about different things, especially when we're organizing a plan of care. And maybe that's exceptional, I would say. But my point is there's a lot of logistics associated with it. There's a lot of even just basic social implications, transportation, out-of-pocket costs for going back and forth. I'm going to grab something from the vending machine while I'm waiting. A lot of those things that we maybe take for granted. But for folks who are going back and forth to the hospital or to a clinic constantly, those things very much add up. I'd also be remiss if I didn't mention our caregivers. This is they're walking hand in hand with their friend, their loved one, whomever. They're also taking time off from work. They're also taking time to drive and kind of help support them, and often emotionally supporting them as well while trying to kind of manage their own feelings. So I think flexibility is really important. That's a hard thing to deliver. I acknowledge that. But there's a lot of priorities that run through our cancer patients' minds as they go through this. And much of it is the cancer itself, but a lot of it is, how is my son or daughter navigating this news? Oh, I'm behind on work right now, or I'm adding more work to my colleague who's trying to help me. And so as much as we're able to be flexible and support folks as they go through this, I think that's really important.
Susan?
Hi, Susan from COPC. So if somebody had a diagnosis from their PCP, are you the gatekeeper? And I don't mean that in a negative way. Yes. But, if they know, so if the doctor says, I think you need to go see Dr. Smith, is the better approach to go through you versus calling Dr. Smith's office?
So we're also always happy to help, try to get the patient in, get them seen, and get this process moving. So, to be clear, we do not see folks who have an established cancer diagnosis. So if they already have the biopsy done and it's back with lung cancer, I'm going to say, thank you so much, but I want to get you to one of our thoracic oncologists, one of our specialists in that as soon as possible. But if it's easier to let us if they're not sure what they're dealing with, we're more than happy to see that patient. And we can usually get them in pretty quickly. I'd say we see most of our appointments within 24 to 72 hours of someone calling in. Right.
Another question?
Rebecca with Genentech. If you could sum up in a couple things for if we think about the employers, why is this important for them to be thinking about?
Well, from the numbers, you're going to have employees who have cancer. I mean, let's face it, you will. I would say that the diagnostic period and the understanding what we're dealing with is as stressful, if not more stressful sometimes, than what are we doing about it. I would say that people will try to keep their life in balance while going through that process, but it's very, very hard to do so. And I would say when we move to the therapeutic side, we're trying to do something about that, no matter what stage of cancer that they're dealing with. Something has to be let go, right? So we may not be as focused on work. Our family, we may not feel like we're supporting as much. So again, that flexibility, that trying to meet folks where they are. I know we think about FMLA, we think about all of those things to try to support our employees, but this is something that takes over and demands time and attention 24/7 when they're going through this. I didn't even get into, but just the side effects. Thinking about when we think about drugs and are they equivocal, are they good? Well, I want to know, what about the side effect profile? Because great if it fixes your cancer, but is it that much greater if it makes you miserable and you can't function? So I think flexibility, supporting, wherever a person is at as they go through this. And then, even when we think about kind of bigger questions of which drugs are we choosing, I really appreciated the comment to let's get providers in this conversation before we just say, this is what you have to do. Because it's when I'm sitting in front of that patient and saying, there's a delay for this, or I'm trying to figure this out, that's time. It's a really hard conversation to have. And so as much as we're able to kind of be collaborators and partners in that, I think that's really helpful. Hopefully that's okay.
One last question, Dr. Reinbolt, that's related to Rebecca's, I think. So if you're an employee benefits professional in the room, if you're an employee benefits consultant, from your perspective, what do you think maybe one or two things they could look at changing to their benefits would be in terms of a priority around cancer care?
So making sure folks have coverage is one thing. Not having good healthcare access, not having good benefits is a challenge. Patients who have, when I'm not having to, let's put it this way, as a physician, I don't really want to think about insurance and what I can, being, truly transparent here. I just want to say, this is what the evidence says. This is the data and studies. This is the best thing for you. And I want to be able to give it to you tomorrow or whenever. So making sure that, I guess, patients first, it sounds very basic, but have the access, have the right, insurance plans, et cetera, have the ability to get to those is really, really important, I would say. And then I keep harping on that flexibility piece, but I do think that's important. Allowing folks to maybe work virtually, being a little bit, okay, you don't have to come in the office this many days. Are there other things we can do? Because I'll be honest with you, I want my patients to work. I want them to stay active. I want them to exercise. I want them to do as much as they can while they're going through a particular treatment. Because I personally believe, that keeping your mind busy, keeping active, I believe is helpful for many patients, not all, but for many. And so how can we meet those patients where they are and what they can do today instead of just saying, you're out?
Thank you.
Sure.
Any final questions? Okay, let's thank Dr. Reinbolt again. Excellent. Thank you.